Welcome back everybody, David here again with Med School Bootcamp. So in this next video, we are now going to talk about renal papillary necrosis. And we start out with the pathophysiology here. Pretty straightforward, but we have ischemia, right? Various things that cause ischemia or lack of blood flow to the kidneys. And ultimately, this is going to damage a particular area and lead to necrosis of the papilla and the renal pyramids. Now, if you draw your attention over here to our kidney diagram, we're going to remember that on our anatomy, the renal papilla is going to kind of be the tip portion right here, which I'm highlighting and circled in red, of the renal pyramids, which are going to be this larger portion of the renal pyramids. Remember also on the outside, we kind of have the cortex out here. We have the pyramids going into the papillas, going into the minor calyces, the major calyces, which ultimately join to form kind of the renal pelvis area right here, which then leads through the ureter itself. So that's kind of the general flow of urine production as it goes from the kidney into the ureter itself. Now, what happens is if we get necrosis of these areas right here, we get obstruction and renal scarring that occurs. So imagine this dies off right here, these cells right here die off, and they can create kind of an obstruction in the calyces itself, which can ultimately block the renal pelvis and block the ureter eventually. So there's a multi-step process by which cells are dying, they're sloughing off, they're getting stuck in the system, and they're causing an obstruction for urine creation and flow. Now, when we think about the etiology here, there's a couple key ones I want you to keep in mind. The first of which is sickle cell disease or sickle cell trait. So I've highlighted disease or trait because it can be either one. And the reason is that in the medullary area or the renal medulla, cells that are typically normally shaped, right, are more likely to sickle under what kinds of conditions? Well, one of which is a low oxygen level, low pH, as well as a high osmolality. So any of these environments, right, are going to lead somebody who has sickle cell disease or sickle cell trait to have a greater formation of sickle cells. Well, the problem is these sickle cells can actually cause obstructions. They can actually clump together and increase the viscosity of the blood. So imagine this right here is a bunch of clumped sickle cells together, and these can cause an obstruction inside the renal papilla and cause a blockage overall. So that's kind of why this occurs. Because there is low oxygen in the renal medulla, this is creating an environment that leads to sickling, and more sickling can clump together and cause this obstruction. The other ones I want you to keep in mind include acute pyelonephritis, NSAIDs, diabetes, and nephrolithiasis. There are some other things that can cause it, such as this can be triggered by an infection, but the ones on the first line are really the ones that they're more likely to test you on. And just to walk through these briefly, pyelonephritis is essentially an infection that has made its way from the bladder itself up the ureters into the kidney. So if an infection ascends this high into the kidneys, this can actually lead to renal papillary necrosis as well. Patients who are taking high doses of NSAIDs, right, this can lead to renal papillary necrosis. And the reason being is that we get decreased renal perfusion because the way NSAIDs work is that they block prostaglandins. Prostaglandins actually dilate the afferent arteriole. And so if we give NSAIDs and we're blocking the prostaglandins, not only are we not going to get dilation of this vessel right here, right, it's not going to be wider, it's actually become more constricted because we're blocking the thing being prostaglandins that cause it to dilate. So if we block that, now it's going to actually have the opposite effect, and we're going to get constriction of the afferent arteriole. Remember, the afferent arteriole is the one that leads into the arteriole itself. So if we constrict it, less blood flow gets into the arteriole, less blood flow gets into the kidney, leading to hypoperfusion, which can ultimately lead to renal papillary necrosis. Now, when we talk about the presentation here, it's going to kind of vary depending on the patient's symptoms. So if they present acutely or if they present with chronic renal papillary necrosis. So acutely, you're going to see colicky flank pain, you're going to see hematuria, and you're likely going to see proteinuria. However, if somebody's presenting with a chronic case, they've been able to develop it over time and they've been able to manage it, you're more likely to see an asymptomatic or a mild case. Now, we need to talk about this colicky flank pain, this hematuria, and the proteinuria, because we know that these are associated with a lot of other kidney injuries. When we think about colicky flank pain and hematuria, right, these are also findings that we're likely to see in somebody who has a kidney stone or nephrolithiasis. And notice the association here between nephrolithiasis and renal papillary necrosis. One can lead to the other, or they can be associated with one another. So it's always important to keep in mind and build a differential. If you see these presentations, the first thing I want you to think of is nephrolithiasis, right? You see colicky flank pain, you see hematuria, I want you to think of that. However, there are sequelae, there are other things that can happen when a patient has kidney stones. Additionally, if they give you a presentation of a patient who has clear sickle cell disease and you start to see some changes in their kidney function, I want you to be thinking about renal papillary necrosis as a possible thing that can occur in a patient who is at a higher risk, a patient with sickle cell disease, and we talked about why that actually is occurring. Now, when we talk about diagnostics here, fairly simple for this one. We're really dealing with our standard labs that tell us that kidney function is decreasing. So we have an increased BUN and creatinine. Why is that? Well, we said that this can create an obstruction in the kidney, right? It can create an obstruction right here. It can create an obstruction right here. As the cells die off, they can create obstructions at various places in the kidney, in the ureter, in the calyces. Well, what's going to happen? Well, we're going to get a backwards pressure. We're going to get a buildup of pressure so that we don't filter our substances as well, our BUN and creatinine. Remember, these are typically filtered at the glomerulus in Bowman's capsule. However, if we have a back pressure coming from other places because of a distal obstruction or obstruction further down in the kidney, that's going to change us from going from a high pressure to a low pressure system. And now we're going to be going from a high pressure system to another high pressure system. And that is why we get a decrease in our filtration of these molecules, BUN and creatinine. Now, when we consider some imaging for this patient, the best test you're going to want to get is going to be the CT urography. And the reason is because this can visualize ischemic changes, but it can do so early on, right? It's one thing to see later on in the patient's pathology and disease when things are really bad. Oh, if they had renal papillary necrosis, what do we do? But early on, if you suspect it, if you're getting some of these classic signs and symptoms, right, and you're working through your differential and you come down to the fact that, well, hey, let's consider this patient might have renal papillary necrosis. They have some of the labs. They might have the presentation. They might have some of the risk factors. Well, now this is a good time to get the CT because you want to try to catch it early if a patient does indeed have this pathology. And finally, when we talk about the management here, we're going to talk about treating the underlying cause. We talked about classic things that can cause it. So if a patient's underlying cause is the nephrolithiasis, it is that they have kidney stones, that would be a primary thing that we would want to treat. Depending on the size of the stone, we might just encourage hydration. We might talk about urology consult, doing things like shockwave lithotripsy, but that's going to vary on the size of the stone. Additionally, you're going to want to consider symptom management, right? This could be a painful thing for a patient. They could be dehydrated. They might need fluids. There are a variety of different things that the patient could be experiencing that is leading to this pathology that we want to manage as we're trying to allow time for the body and the kidneys to work on healing themselves. So a classic vignette they might give you for this pathology could be something along the lines of a 47-year-old patient with a history of sickle cell presents to the emergency department. The patient notices that they are starting to experience more hematuria in the urine, which is new for them, and they are kind of concerned by these new findings. You determine through questioning that the patient's not having any pain with urination, they're not having any frequent urination, and that the patient does not have a history of smoking. Now, you get some labs done, and on those labs, they show you your classic increased creatinine and BUN indicating kidney involvement. Your urinalysis also shows you some hematuria, some blood cells that are in the urine, as well as some proteinuria, and it tells you there's some necrotic tissue that's present as well. Well, the hematuria and the proteinuria could be a variety of different things in the kidneys. However, the necrotic tissue, the necrosis, right, that means cells are dying, they're sloughing off, that is going to be more indicative of a renal papillary necrosis. So this might be a way that they can present this to you. And also keep in mind, they said in the first sentence that the patient has a history of sickle cell. So they're giving you a clue that this patient has an increased risk of this particular pathology to begin with. So real quick summary for this video, just think about the name. It's renal, so kidneys, papillary, that's the area that we're typically talking about, and necrosis. So ischemia leads to necrosis of this particular area of the kidney. I also want to know something that this is typically bilateral, which if you recall from our last video, this is also typical in diffuse cortical necrosis, which was dealing with more of necrosis in the outside of the kidney or the cortex itself. So keep that in mind. Both of these conditions typically are bilateral. That doesn't mean they're always bilateral, but that's the most common type. Now, when we talk about the etiology here, there's actually quite a few that could be listed. This is not all inclusive, but the primary ones I want you to remember I have on this line right here. I think the ones I've seen most commonly tested include sickle cell, NSAID use, right? We talk about how this decreases renal perfusion to the kidney, which makes sense. This ischemia can lead to necrosis and nephrolithiasis as well. They'll kind of give you a hybrid presentation of a patient who might have a kidney stone, they might have the colicky flank pain. Oh, but hey, they're actually having significant hematuria and potentially some necrotic cells as well. When we think about the diagnostics here, we want to keep our differential as broad as it can be, but we're going to see our typical expected findings in kidney injuries, including an increased creatinine and an increased BUN. We're likely also to consider getting a CT urography, and the reason is because this can detect the ischemic changes, but it can detect them earlier on than we might notice for a patient. So if we get that imaging, we see the changes are occurring, we can begin to move on to our management section, which is to treat the underlying cause and provide symptom management and support for the patient as their kidneys work on healing themselves.